Welcome to the channel, and today we're going to discuss a very interesting case of a yellowish type of lesion present in the supratemporal part of the orbit. If we look over here, this is this area of the orbit where you're seeing this yellowish lesion, and this is present on the supratemporal quadrant of the orbit. And the patient did not present any complaint. There was no proptosis in this patient, and retropulsion. The eyeball was soft on retropulsion, so there was nothing that seems to be behind the eyeball. So there's an entity which is called an orbital fat prolapse, which we were seeing in this patient. And let us see how it looks like when you go in and ask the patient to move the eye in different directions. So it's just, I'm lifting the patient's eyeball, upper lid forward, and what I'm trying to do over here is I'm trying to push that eyelid over the yellowish fat. This is actually orbital fat, and the orbital fat is a tissue which is present around the eyeball, and it acts as a cushion or a shock absorber, so it prevents the eye bobbing up and down, and it prevents its when it takes an aftershock when you hit something, and it's something in which the eyeball can smoothly move with its muscles around the eye. And with age, that the septum that sort of protects that fat from coming beneath the subconjunctival tissue or subtenon tissue becomes lax. As you get, the skin becomes lax and you get fat prolapse in the lower lid bags as well. So this is some type of a bag which is present there over there. And it's typical if you press it with a Q-tip or with your finger, and if you can push it back and take it back, that means that this is an orbital fat. And if you cannot take it back, then obviously it will be a differential diagnosis. Is most common over here is a lacrimal gland tumor, which can be a serious disease. But this is something which is not serious, but it is more of a cosmetic problem for the patient. So if you want to tackle this disease, one can do a MRI or a CT scan just to see it's not connected or there's no tumor behind or no growth behind, and you need to measure for the proptosis and for dystopia to see the patient does not have anything like that. And the patient was just dilated for a dilated frontal exam in which you see the pupil dilated in this. But the main thing is how you can treat this patient. And the major differential diagnosis is a dermolipoma. A dermolipoma is something which is not going to be compressed by the finger, and you cannot move it back. And with a dermolipoma, you will have a hair coming out from the fat over there. So that is a congenital problem. This is a problem which is present at an older age group. This is an orbital fat prolapse. So what can you do for this? So you need to give a conjunctival incision, and you need to carefully tease out that fat, and then need to use a clamp to cauterize that to sort of produce hemostasis, and then cut it with the scissors and then do cautery to the fat. Because if you cut the fat and there's bleeder and that goes back into the orbit, you're going to be in trouble. You will get a proptosis, and you might do a lateral canthotomy, cantholysis to prevent compression of the optic nerve. So this is something very important to do. Or the other thing is you can use a cutting cautery or a bovie to cut that fat along anyway. So it's always better, because when the patient is lying down during surgery, you tend to cut less of the fat so you can reduce as much of the fat as you can remove. And the other very, very important thing when you're removing this fat is that you need to look out for that medial rectus or the superior rectus muscle, that you do not incorporate them into your excision. So I always tend to do it under a microscope to give you a good view and give a complete excision of the growth as there. And it's very nice conjunctival incision that heals very nicely there over there. So thank you very much for watching. Please do subscribe to our channel and press the like button. Thank you.